What's up, everybody? My name is Daniel Unmanageable, and this is Hard Knocks Talks, coming at you from Treaty 6 territory and the traditional homeland of the Métis people in Saskatoon, Saskatchewan. Today, we have a couple of guests joining us to bring awareness to the upcoming Methadone-Methadose transition in Saskatchewan. First, we have Matthew Bonn, person with lived experience with the Methadose transition in Nova Scotia in 2016 and member of the Canadian Association of People Who Use Drugs. Matthew, how are you today?
I'm doing pretty good. How about yourself?
I'm doing well. Let's bring in our next guest. Next, we have Saskatchewan pharmacist Amy Wiebe. Amy has been tasked with bringing awareness to the Saskatchewan transition and thought what better place to do that than Hard Knocks Talks. Hey, Amy, how are you?
That's right. Hey, I'm doing well. Thanks for having me here. Really excited.
Your sound is so good. I really love that headset. I know I was giving you accolades before the show, but it's just amazing.
Most people make fun of me, so it's all good.
Sorry, you guys, I have a bit of a cough. I'm doing my best here. Matthew, is there anything you'd like to say before we jump in?
No, I think it's great that we have someone like Amy on the call and that there's still time to maybe advocate to not let that switch happen in Saskatoon. So as much awareness we can get out there, the more lives we'll save.
Awesome. Amy, anything you'd like to say before we start grilling Matthew here?
Yeah, no, I'm just really looking forward to exploring kind of what's happened in other parts of the country and also hoping that people feel like they can have their questions answered about what's going on here. So let's get into it.
Awesome. All right, Amy. Well, we're going to take you off the screen for now, and Matthew and I are going to have a bit of a conversation. Feel free to chime in whenever you like, but see you in a bit.
Will do. Thanks.
All right, Matthew. First of all, thank you so much for being here today. Thank you for bringing your expertise to the conversation. We very much appreciate that, and we hope that we can bring some awareness to the people in Saskatoon and across Saskatchewan in the MAT program. But why don't you tell, let's see here, where are we going? Why don't you tell us a bit about your transition from the illicit supply to methadone in 2012?
Yeah, so I guess back then it was more in Nova Scotia. We didn't really have a lot of heroin, so it was mainly prescription opioids.
Mm-hmm.
And I was using prescription opioids at the time for, I don't know, 6-7 years. They're very easy to get, but just like any kind of drug use, it becomes unmanageable to a point if you can't get the supply. And you need some kind of treatment. Back then, the wait list for the treatment was like a year to 18 months, which is insane, right?
So
like
when you talk about treatment, are you talking about like inpatient treatment, or are you talking about a maintenance program?
I'm talking about maintenance program, but the inpatient treatment was very horrible as well. Like you never knew when you were getting on into inpatient.
Mm-hmm.
And so when I transitioned, I actually, I acknowledge I'm a white settler, and my dad actually knew the lady that ran the clinic. So my last time in detox, I got in because he reached out to her and got me into the methadone program. Honestly, it was great for the time being. Like, I didn't have to hustle every day. I didn't have to commit crime. I didn't have to sell myself. I didn't have to sell drugs. I didn't have to do all those like moral things that I didn't want to do, or immoral things that I didn't want to do. But it just never really cut it, right? Like, you can drink methadone and it works. It takes your withdrawal away, but you don't get high from it. And at that time, I was very much still wanting to get high.
Mm-hmm.
And at that time, you had to go every day to downtown Halifax, which the Halifax Regional Municipality is, if you don't live right downtown, you got to travel. And sometimes it took me 45 minutes to travel to get my methadone every day, which is a lot.
Mm-hmm.
Can't work. It's really hard to have any kind of lifestyle. I always said, being on methadone is a lifestyle.
Yeah. It's a liquid
And
liquid leash, I've heard it called.
yeah, liquid handcuffs as well, right?
Mm-hmm.
And very much so, that's what it was. Back then, Suboxone or buprenorphine, whatever you want to call it, wasn't available either. It was just kind of becoming available for youth.
Mm-hmm.
So I think you had to be like between the ages of 17 and 24. Um, but like I did okay. I can't
Yeah.
say, like I did it once and I weaned myself off it. I did great. I struggled a lot. I used a lot of benzos. I used a lot of cocaine,
Mm-hmm.
and that obviously limits um, your program, right? Like
Yeah.
you can't get take-home doses. They don't trust you anymore. You do more urines, right? Like it's just
Mm-hmm.
you always seem like you're failing, right?
Yeah.
And I always say like you should like if you can be honest with your doctor and go in and say, look, I don't plan on stopping using cocaine. What's the problem? Like, why can't I have take-home doses of methadone, right?
Mm-hmm.
Um, I think having those relationships with doctors, honest ones,
Mm-hmm.
that's what we need more of, right? And I don't think we see it a lot in opioid agonist therapy or medication assisted treatment.
Yeah. Yeah.
But like that was back in 2012.
So
Um,
sorry to interrupt you, but so what you're saying is it did bring a certain level of stability to your life? Like, did it reduce the harms in your life while you were on methadone?
yeah, definitely, right? Like it
Mm-hmm.
definitely helped.
Mm-hmm.
But it didn't. I still wanted to get high,
Yeah.
and I think that's really kind of what caused me to spiral a little bit. I still did good. I got a car, I got an apartment, things I didn't have before. Um, and I was
Mm-hmm.
working a pretty good job, and like I actually weaned myself off methadone once, started using again, going back on it,
Mm-hmm.
and that's when I really noticed the switch.
Oh, so you went off of it, and then that's when the transition happened?
I went off it, then I started using again, went
Yeah.
back on it, and then I was doing good for a while, and then I just started struggling again, and I had no idea why because I did good before on it, right?
Mm-hmm.
Um, and I didn't even hear about this switch until Crackdown and listening to Garth Mullins and
Mm-hmm.
seeing what happened in BC. Um, but what I did notice in Nova Scotia was them all switching to these measure machines where you put your thumbprint in and it automatically dispenses the methadone. And I
Mm-hmm.
thought that was strange. Never
But it
really
wasn't
thought
it
too much.
it wasn't methadone though. So that was when they made the transition. So when this first started happening to you, when you first started noticing symptoms and stuff, did you think this was like all in your head? Did you go to your doctor right away and say, "Look, something's not right"?
I went to my doctor eventually, but no, for a long time I thought it was me. I
Mm-hmm.
thought, oh, I just can't get it. I'm just going to be one of these people that I'm always going to use.
Mm-hmm.
Like I'm one of the um, people that can't be honest with myself, or like,
Were
and
you?
that really fucked that messed with me for a long time, right?
Mm-hmm.
Because like I tried hard. I went to meetings, I had counselors, like I had a great support system, but I just couldn't stop using, right? And like I ended up in jail. I overdosed. I don't know how many times, and I just thought I was the mess up.
Yeah. Um. So tell us about the day that you finally like. Did you go to the doctor and say, "Look, this isn't working someday, or for some reason," or how did you end up to the finding out about the transition?
Yeah, so um I used to ask questions to the nurses and stuff, and they told me, "Oh, this is just a different formulation. It's more diluted." I still didn't know it was methadose and whatnot, but then word started to get around a little bit. Like people also noticed it. Like people
Mm-hmm.
were waiting in the morning to get their dose at like like an hour before the clinic opened, right? So eventually, when I talked to my doctor about it, and I think he's read some of the studies on it, he actually gave me some morphine to top it off, right? Like
Hmm.
I have a pretty good relationship with my doctor, so um, like he's pretty much saying, "Oh, there's nothing I can do." He's given me Methadone pills that were really helpful. But when I was on the dose, because I overdosed a few times, he wanted to keep me on a liquid dose. He just gave me a little bit of morphine to top it off. Um, but like I said, like I have a doctor that's like a needle in the haystack, right? So
Yeah.
it's like
Yeah.
not too many doctors are like that.
Hmm. So when you made when the transition was put upon you, did they transition you to Methadose or Methadol D or Metadol D? Sorry.
So it's Methadose, and then when I went to Metadol D, I was traveling and I was going to BC for like 3 weeks, and obviously that's a lot harder to carry 3 bottles. So my
Hmm.
doctor suggested, oh well, there is Metadol D that people take for pain, which is the exact same as methadone. So he kind of transitioned me onto it, and then I just stayed on it, and then I weaned myself off that again. Um, and then more recently, like I was struggling again, I'd say more because of the toxic drug supply, but I called him and I was like, I can't go every day to the pharmacy. Like I can't do that. And he worked with me. He gave me like 3-day carries of Metadol D. He's very open minded and he's very, like he wants what's best for me, and um it worked, right? So I'm not
Hmm.
on any opioid agonist therapy now.
Did you ever have any experience with other providers before you found this doctor that you're working with now?
Yeah, I'd probably seen every doctor in Nova Scotia. Um,
T- Tell us a bit
some
about that.
some some of them are great. Some of them are abstinent themselves. Like some of them practice recovery as well, and I find it's almost like a conflict because they try to put what worked for them on their patients,
Hmm.
right? Um, so I've had some issues around that. None of them like prescribing benzos, and I've always had acute anxiety. I was prescribed benzos at like 17 years old, right? So
Hmm.
when I had to choose between the two, um, it was really hard for me, right? I had a safe supply doctor who was amazing. She's probably she's a friend, she's a colleague, and she's a great doctor.
Hmm.
Um, and the only reason why I got into the doctor I got in now is because I had hepatitis C, um, and I didn't want to stop using drugs, and I told my Hep C nurse practitioner, like no doctors will take me. I didn't have a family doctor at the time, and she's like, "Oh, I know a doctor that will take you on." I got a methadone doctor, but I didn't have a family doctor.
Hmm.
Um, and she's like, "Oh, I know the perfect doctor for you then." And then I got in the next day, and I tried to weasel my way into his office so many times. "Oh yeah, I'm a patient." Call him up, and they're like, "Oh, we don't have your chart." And so I tried to get in a few times, and now we're like real tight.
Hmm. So when you were on Metadol D, did finances ever become a barrier for you? Because what I understand, and maybe this is going to be different in Saskatchewan, I'm not sure. Maybe we'll pick Amy's brain about that. That there was an additional cost associated with Metadol D as opposed to the Methadose.
Yeah, you have to pay for Methadone D, and it depends how much you're on, right? When I
Hmm.
first got on Methadone D, I was on 20 milligrams a day, I think, and um, I would just pay. So every time I picked up my carries, I paid like 20 or $30, which wasn't bad. But then the most recent time I was on Methadone D, I was up on like 50, and I was paying like $50 every time I picked up, right? So for it to be sustainable for opioid use disorder, I would say there's a huge barrier, financial barrier there, right? If someone's on 100 milligrams of
Mm-hmm.
Methadol D or whatnot, like that would become an issue, I would say, really quick.
Mm-hmm.
I don't know why they don't use it more often. Like, I think it's a great tool to help wean people off, or for traveling, for people working on the rigs, or doing construction work, or
Mm-hmm.
anywheres where it's hard to like travel with bottles. um I feel like we need to start looking at alternative options.
Hmm. Well, let's bring in Amy here just for a quick sec, see if she's got anything to add. Hey, Amy.
Yeah.
Um,
Hello. Thank you. Thanks. I do have some comments about what we have available in Saskatchewan because it is a little bit different from Nova Scotia. Is it okay if I just jump in right there?
the floor is yours.
And some people might not even know what we're talking about with regard to the transition. So maybe this is common knowledge for some people who are watching, but not necessarily for everyone. So to say that in the past, pharmacists were preparing methadone in the pharmacy using powder and mixing it together with water to get a solution and then mixing that together with juice. So that was what was done in Canada up until first the switch happened in BC in 2014. Sounds like the switch to commercially available products happened in Nova Scotia in 2016. All of the other provinces in Canada have now switched to the products that are commercially available, other than Saskatchewan. So Saskatchewan is the last that's making the switch right now. And what I mean by this is that manufacturing companies are making this solution. So it's coming to the pharmacy with the medication, which is always methadone. Methadone is in every single one of the medications, but it's coming to the pharmacy in liquid form. So the pharmacy doesn't need to get involved with mixing it up from powder. And sometimes that's where some of the error or risk can come in when the pharmacies are doing that.
Mm-hmm.
So in Canada, there's actually 6 different kinds of the commercially available methadone. And it gets confusing because they have different names. Most of them have, or I guess half of them have brand names. Like when we think, Tylenol and acetaminophen, the brand name is Tylenol, the generic name or the actual drug name is acetaminophen. In this case, there's methadone in all of the products. That's the generic name. But then the brand name is Methadose or Metadol, and then there are some other kind of like no-name brands which are available in Canada, but they won't be in Saskatchewan. So when we talk about Metadol, just to clarify Matthew's comments, in Nova Scotia, they have Metadol tablets, which are officially indicated for pain. So that's why he was having to pay out of pocket, because the drug plans, the insurance providers, won't pay for it if it's being used for something other than what it's indicated for, which is for pain. Whereas in Saskatchewan, what we have is Methadol D, which is the liquid form, which is indicated for like the medical term of opioid use disorder. So I'm not sure if that helps to clarify that in Saskatchewan, we have 2 kinds of Methadose and Methadol D. Those are
Mm-hmm.
the only 2 products that we will have here or have here right now. But it's a
That's
little bit
actually
different in Nova Scotia.
that's actually very informative. Yeah, I wouldn't have known any of that.
Yeah.
So what you're saying is that Metadol D will in fact be covered in Saskatchewan. There won't be any additional
It
financial
will.
barriers.
No.
Okay,
Yeah, it is
awesome.
on the drug plan, won't cost anything additional to get the liquid Methadol D. Yeah.
Hmm. Okay. Well, we'll take you off screen again for now. If you got anything else, don't be afraid to pipe up.
Okay, will do. Thanks.
So, Matthew, where do you see the biggest challenges being faced by those trying to find stability with MAT in Nova Scotia?
Oh, that's a great question. Um, right now, I would say we're having an increasing uh very toxic drug supply, which typically, we had prescription opioids, and I'm a big advocate for safe supply. So if we had prescription opioids, they're a lot safer than, fentanyl, carfentanil, benzodope. So I would say a lot of people are becoming dependent on, fentanyl and these other fentanyl analogs. So when they go and try to get on medication-assisted treatment, it just doesn't cut it anymore, right? And then they can't get carries. There's also like income assistance. So, like if you're on income assistance, it's covered, but if you're doing good, you're on, you're stable, you start working, then you still have to pay for your methadone, right? Like unless you have like pharmacare through your work or whatnot, and sometimes it's quite pricey. And you see a lot of people kind of like not be able to pay for their dose. Um, I think we need more options like for medication assisted treatment. We're getting there. There's a few doctors that prescribe hydromorphone. There's a few doctors that will do like injectable buprenorphine, which has been very progressive in the last little while. But housing is a huge issue. I would say, like people trying to get, it's like a circle, right? Like if people want to get on methadone or buprenorphine, they can do it through a shelter, but if they really want to be stable on it and get take-home doses, they need
An address.
An address, and they need a place to live, right? And in Nova Scotia, we just don't have the homes, right? Like we have such a shortage of homes, let alone affordable homes, and the prices just continue to go up, right? And I'd say the capacity of doctors, we don't have as many doctors as you would in Toronto or in BC or in Alberta,
right? Amy, just briefly here, and I don't know if you're going to be able to answer this question or not, but when Matthew's talking about housing and prescribing, is there going to be a barrier like that in Saskatchewan?
Yeah, I think I'm probably not the best person to speak to housing specifically, but I can speak to access to prescribing for medications, medication-assisted therapy. I know that we don't have nearly enough prescribers in Saskatchewan, and we need more. I think the list is growing. But it still can take some time, typically, depending on where you live, of course. In Saskatchewan, some people in more rural communities are going to have a harder time finding a prescriber than they might in, say, Saskatoon or Regina. But then the other piece is even like pharmacies. I think probably only about half of the pharmacies in the province dispense medication-assisted therapy right now. I'm hoping that that'll change. We're working to try and make that change and help that number to grow. But certainly that's access is an issue for people here too. I think that's shared probably across many parts of the country.
Well, I think Donna wants to jump in here.
Just a quick thing. I'm not sure if maybe something got miscommunicated in there, but I'm thinking maybe what we're wondering about is if you don't have a fixed address in Saskatchewan, is accessing the treatment going to be a barrier? I think that's what Matt was alluding to a few moments ago. Is that going to be the same here, or?
Yeah, like so I think, I mean, getting...
Have you had that experience in your prescribing practice, like when you've done prescriptions in the past? Has not having an address ever been a barrier?
I would say not having an address or not having a health card can be a barrier to getting coverage for the medications. And I would say that not having an address can be a barrier to getting take-home doses, but not necessarily like witness doses, as long as the coverage piece is in place. Yeah, thanks for that clarification, Donna.
Yeah. Okay.
Yeah,
cool.
That's what I was kind of alluding to. I think it's a barrier for stability, right? You know what I mean? Like if it's hard to be stable on methadone in a shelter. So if people want to do good in these programs, I think housing is, a huge part of that.
So, when you how are you seeing prescribers change their prescribing practices to promote harm reduction strategies? Like, say, and let me clarify maybe a little further. You have this wonderful relationship with your doctor where you can have access to get topped up if you need to be in some circumstances. How did you advocate for yourself to gain that relationship, to build that trust?
Oh, geez. I think I was always just straightforward with him. Like I remember I did a media interview for him, and he has a really great case manager who's a former person who used drugs. And I remember the title was Prescription for Change was the media kind of thing.
Mm-hmm.
And ever since then, we're really close. And I think, more and more we're seeing doctors and students listen to people, right? Like listen to drug user groups, listen to people on methadone. Now, I always say like focus your time on younger doctors or med students because it's hard to like change, somebody who's been doing this for 20 years and has their own way of practicing. Um, but I've seen a big change, I would say, since like 2018, 2019. And then with COVID happening, I felt like, some people got their carries that may never got their carries. And you could do telemedicine. Like I really don't think you have to go into a clinic every day to tell your methadone doctor you're doing good. Like you should be able to do that over the phone, right? Maybe do urines quarterly or something, right?
Mm-hmm.
And I'm slowly starting to see that happen. I don't know what impact it's having, but I feel like it has had an impact on me, and I'm sure others as well.
Mm-hmm. So, has stigma ever prevented you from accessing services as a person who uses drugs?
All the time, yeah. Like I remember when I was diagnosed with hepatitis C back in 2012, right around when I got on methadone. Um, and I was always very, respectful and whatnot. So if I was having, you know, consensual sex with someone, I'd tell them I had hepatitis C and wear a condom. Or if I was injecting with someone, I'd tell them. But that was the community. I had a very hard time going into healthcare providers to talk to them about it, and if it wasn't for that great nurse practitioner that linked me to my great doctor now, I don't know if I'd be treated for it.
Mm-hmm.
And then finally, when I did get treated for it, it was like one of the most lovely doctors and nurse combinations I've ever had. Right, so I've experienced both sides of it.
Mm-hmm.
Um, and I think it's I do carry some privilege, um you know but I'm also an open book too, and I feel like that goes a long way.
Mm-hmm. So you are a member of CAPUD, and that is the Canadian Association of People Who use drugs. Um,
Yeah.
can you tell us a little bit about how your organization is working towards better services for people who use drugs?
Yeah, that's a great question. So we're a national drug policy organization. Our whole board is made up of people who use drugs. All our staff are people who use drugs. We have our national headquarters is in Nova Scotia, in Dartmouth. We have employees in Quebec, um, and and Toronto. Right now, we mainly do policy work. We don't do as much service delivery, right? Like I feel like our skill sets do a lot of we do a lot of research, a lot of engagement, a lot of knowledge translation. Most recently, we actually changed Health Canada's exemption to allow people to split and share in overdose prevention sites. So before that was considered trafficking, right? You can't hand someone drugs, that's trafficking.
Hmm.
So we advocated, we did a little bit of research, we met with the government, and now you can do that. So I think we do things like that more so. We
Mm-hmm.
also do like a lot of naloxone training. We're working on doing some drug testing here with this new innovative drug testing machine. But yeah, I'd say we mainly do a lot of research lately that impacts policy.
Awesome. Okay, so we're going to bring Amy back on here, and the three of us here are going to have a bit of a conversation as far as how can we best advocate to prescribers who don't support harm reduction strategies.
Yeah, for
So,
sure.
Yeah. Well, that's a big question in terms of not supporting harm reduction strategies. I think, as Matthew alluded to, some clinicians who have been around for a long time haven't necessarily received training on how to support people who use substances in school and maybe have some fairly strongly long-held beliefs. Not everyone. But I think in fairness, that training is changing, and we're starting to see that education is being built into providers' required training for pharmacists, for physicians, for nurse practitioners, which I think is really great to see. And more evidence is coming out all the time about how harm reduction is very evidence-based and how important it is for people to figure out where they're at, what they need, and help them get those things. With regards to methadone specifically, I think there's a difference between not supporting versus not knowing. I think there are a number of prescribers who support harm reduction but don't necessarily know about some of the issues or what the word on the street is around the change in methadone, and don't necessarily know how to approach it. And so that's actually where my organization comes in. I work at the university. There is a website that's available. I might get Donna to just put the link in the chat if you can, please, Donna.
On it?
It's a program called, thank you. A program called MedSask based out of the university. And it's actually pharmacists who are kind of on call. Anybody can call them at any time, whether you're a care provider or whether you're a person who's using services. You can call these pharmacists in Saskatchewan to ask questions. And there's a website with some resources available. So we have done some work around the methadone, the change in methadone, and there's education there, because I know a lot of people have said, my doctor doesn't know anything about this, my pharmacist doesn't know anything about this, and we are working hard to try and change that. That's where you come in, that's where Matthew comes in, trying to have this conversation, as well as directing people to that website. So if people are talking to their pharmacist or their prescriber, and they don't know about the change in methadone, can share that link with them to say, hey, here's some more information. And I think the bottom line that I hope that people will take away is that when we've looked at the different methadone products that are available in Saskatchewan, while in theory the products should be the same, they're all methadone, they're all the same amount of methadone, they might not work the same. That's what people are saying in terms of their experience. And so I've heard that specifically with the cherry flavored Methadose out of BC, that's what's in the reports. They've published some literature that describes their experience. And I've also heard good things about Methadol D. And so for the most part, we're saying, we want people to know that they have a choice, to have the information, to have the conversation with their prescriber, with their pharmacist. And based on kind of all the considerations, personally, when I look at it, I don't see a reason why you wouldn't pick Methadol D. I think that's the best option to pick. And if people go into their appointment with the information, then they can advocate for themselves and what they're hoping to get with the change in methadone, so that they can successfully change over without having any negative effects.
Awesome.
Long-winded answer.
No, that's fine. Donna wants to chime in here for a sec.
So I'm kind of curious, in terms of clinicians and whatnot, how is the College of Physicians involved? Are they encouraging knowledge be shared amongst clinicians, or because I know the College of Physicians is a huge factor in how clinicians approach different things. So I'm wondering, how involved are they in this process, and are they supplying information to the clinicians that would allow them to make a better decision for their patient?
Yeah, no, for sure. That's a great question. So, and if you look on the website, there are a few different handouts that are available there. There's a two-pager document that was developed specifically for prescribers. So, there are specific physicians who have authorization to prescribe these medications through the College of Physicians. And the same goes for nurse practitioners. There are specific nurse practitioners who can prescribe through their college. All of those colleges have specifically sent that two-page document out to anyone who's a prescriber in Saskatchewan. So that information has gone out. You know as well as I do that email isn't necessarily always the best way to get information out. How many of us have like thousands of emails sitting unread in our email box? But that distribution has been done. And then there was also a presentation that we had done for care providers as well to try and get the information out there to them. So we do have the support of the colleges, and we're trying to take a few different avenues to get the word out there.
Awesome. And just for our listeners and viewers that may be watching the recording, if you're not watching this live, we're going to make sure that that link's available in the description of this episode. So if you're looking for that link, you can look in the description. Matthew, do you have any final thoughts as far as suggestions that you may have for the people of Saskatchewan when approaching their doctor with questions about the transition?
I think the BC Association of People on Opioid Maintenance has a great tool when advocating for Methadone D. And I think really you need to have a 1 to 2 pager of this is Methadone D in liquid, this is Methadone D a pill format, this is Methadose, this is safe supply. And really be and then almost have a list for doctors. Okay, well, are you planning on stopping using? And if you say no, then okay, maybe safe supply is better than methadone for you right now, right? I think the way we look at opioid agonist therapy right now is backwards, right? I think we should be giving people a regulated supply of drugs that they're using, and then when they want to stop, then we start to transition them on to more of the treatments, right? And I think you'd see a lot more effectiveness. And I think even a lot of people would even start to come off, right? I feel like I've known people on safe supply that it works for a bit, and then it's a lot easier to come off pills than it is to come off of, methadone that's in your body and longer lasting. So I think if you had some real kind of toolkit for patients and doctors, I think it'd go a long way.
Awesome. Amy, any final thoughts?
Yeah, I think education is a big piece, and the environment that we're in is constantly changing. Like when I think about where we came from, which was like this medical model where care provider knows best, that's changing. It's slow, but it's moving. And so when I hear Matthew talk about how important it is to listen to what people need and what they're asking for and be able to meet them in those places, it makes so much sense. And I think we've got a ways to go. Safer opioid supply is not well or highly utilized in Saskatchewan yet, but I think we're seeing it happening in other parts of the country, and all things always come here that are happening in other parts of the country. We're just usually a little bit behind. But yeah, so that's why I'm so grateful for Matthew for being here and sharing his experience. And I think as long as we band together and continue putting forward our best foot to get the word out to people, and help people feel like their voice is being heard when they're talking with pharmacists or talking with prescribers, that's the goal. So yeah.
Awesome.
Can I ask one quick question before we go? Matt, you had mentioned a resource through the BC chapter, I think it was, or something, out of BC Drug Users Coalition or something. Do you have a web address that we could maybe put a link in here, or can you maybe provide that to us later so that Dan can put it in the description?
I don't have it right on hand, but I can send it out to you. There's the BC Opioids Survivor Guide, but then there's another one that's around safe supply and like advocating for your doctor for Methadone D, but that's a little bit harder to find.
Okay. Yeah, if you want to just send those our way, we'll make sure that those get into the description as well, and people can use that as they see fit. Okay,
Awesome.
I think we've come to the end, guys. Unless there's anything that either of you would like to add, we will let you get on your way.
The only thing I
Thank
should
you.
say, I guess, because this, if I can jump in, sorry, because this is a recording, people aren't going to necessarily know like the timelines. So just for anyone taking methadone, people will need to be changed to one of the new formulations before November 30th, 2022. So that's kind of what we're working with. If people haven't been switched yet, it will be in the next month and a half or so. So hoping that this helps.
Okay.
Thank you.
All right. Thanks so much, you guys. We'll let you go. Take care.
Take
Thanks
care.
so
Thanks
much.
for having us.
Take care.
Okay, so let's see, what am I doing here? We are wanting to throw a shout out to the Canadian Research Initiative in Substance Misuse, Prairie Node, for supporting this event. If you like what you heard here today, jump over to Apple Podcasts, give us a review, and I guess that's it for today. So thanks so much, and take care.